My name is Atul Kishore. I'm the Chief Revenue Officer for Seva at Home, the company that brings you this webinar. We've had a lot of webinars in the last 1 year, but this one today is particularly special because it deals with the matters of the heart and to bring to you myths and facts and to answer some of your questions. We have for you today a very renowned and eminent doctor from the Fortis Memorial Research Institute, Gurgaon. Dr. Vinayak is the director and head of the Department of Clinical Cardiology and Cardiac Imaging, with over 25 years of experience in managing patients of cardiology, cardiac imaging, and also he's been dealing with interventional cardiology. You will find that he's just the right person to answer your questions. In Seva at Home, we started off with a home healthcare company. We forayed into corporate wellness and now a health and wellness concierge. We do medical rooms for corporates. We do health checkups for corporate employees. We provide ambulances, and we are also now launching what is known as a cardiac rehab program, which is the first of its kind in this country. And you will find a lot of questions on that tonight answered by Dr. Vinayak. Dr. Vinayak is the fellow American Society of Echocardiography. He's also the fellow of American College of Cardiology, and he's also the fellow of American Heart Association. An eloquent speaker, a wonderful personality, and somebody who you can really depend on. So over to you, Dr. Vinayak. He will make a presentation, and then we will move on to answering questions which we will take from you. You can write in the Q&A box or in the chat box. So welcome, Dr. Vinayak, and over to you.
Thank you, Atulji, and thank you for that kind introduction. In fact, I genuinely enjoy this kind of a talk because I firmly believe that there are a lot of myths and a lot of wrong kind of information floats around in the common arena. And the major reason is that people with the right perspective don't talk about what health, especially what heart health is all about. My talk is not a talk. It's not like I'm going to show you too many slides or I'm going to talk too many facts, but I'm going to try and burst some of the myths and take you through what health in totality is, especially focusing on the heart. Now, traditionally, when we say heart disease, we basically mean coronary artery disease. So this is what a heart looks like from outside. There are 3 coronary arteries which run on the surface of the heart. And whenever there is a plaque deposition in one of the arteries in the inside, so these are that lipid-laden plaques which obstruct the flow, we call it coronary artery disease. Coronary means these arteries which supply the blood to the heart muscle, and disease because this is a plaque formation which is occurring inside the coronary arteries. Now, these plaque formation, or what we call as fatty streaks, start developing as early as 1 year of child. Even in an infant, if we do a autopsy due to some reason, even in a very small child or infant, we will see that in the coronary arteries, you can find these fatty streaks, which means that the fatty deposition starts as early as a 1-year-old child. So you can imagine that in 30, 40, 50, 60 years, it is not very surprising that our coronary arteries will have lots of plaques if we don't take care of them. Now, what is a heart attack? Heart attack is simply, if I show you this animation, this is one of the coronary arteries which is flowing on top of the heart. This is a plaque. Yellow is the plaque which is deposited inside the artery. There is a plaque rupture or breach. So there is a formation of a clot at this point, and a rapid clotting cascade gets stimulated, and you can see the entire artery gets blocked and damages the heart. So this is known as heart attack. A lot of people mistake this as cardiac arrest. This is not cardiac arrest. This is heart attack, or what we call in my language, myocardial infarction. Cardiac arrest means if the heart has stopped beating. So this is not cardiac arrest. This is heart attack or myocardial infarction, as we call in my scientific language. Now, why is it that we're talking about the heart today? The reason is that you hear a lot about cancers, you hear a lot about AIDS, you hear a lot about communicable diseases, even COVID, for example, dengue, malaria, etc. But hardly anybody talks about the impact of cardiovascular diseases in our life. Now look at this data, which is about 15 years old, actually, and you can imagine that this would have actually worsened over the last 2 decades. Look at the distribution of deaths across the world due to chronic diseases. So look at the cardiovascular diseases, which is basically heart attacks, strokes. Strokes basically means paralysis, heart failure, sudden cardiac deaths. They constitute 50% of all deaths, whereas cancers are about 20%, COPD due to smoking and air pollution is about 10%, HIV/AIDS is about 8%, tuberculosis 5%, diabetes standalone as 3%, and malaria or infectious diseases are much lower in today's world because we have very good antibiotics, anti-malarials, and anti-infectious drugs. Another very important statistic is if you look at the loss of productivity of an individual in a lower or lower middle income countries like India or Asia Pacific, you can see that the maximum loss of disability adjusted life years, which means I get injured or I get a disease, I'm not going to be able to go to work. That is called disability adjusted life years or DALYs. And you can see that the number one cause of deaths worldwide is cardiovascular diseases, and number of DALYs, disability adjusted life years, is again cardiovascular diseases in number 3. The first two, very interestingly, is injuries and mental health. Can you imagine that one of the major reasons why people do not come to work or are not efficient at work is because of injuries and mental illnesses? And again, this emphasizes the very fact that we don't give too much of credence to psychosocial health, which is very, very important and also a big contributor to cardiovascular diseases. Now, if you look at the healthy heart, the first and most important part is awareness. Unless I'm aware that there is a problem, I'm not going to do anything about it. And one thing which I want to mention right here is that in the last 10 years, we have seen a very steady decline in the age group of at what age we get heart disease or strokes in India. In fact, 50% of individuals who come to my emergency today with heart attack are less than 50 years of age. Can you imagine this? 1 in 10 individuals who gets a heart attack today is less than 40 years of age. So younger and younger age group of people are getting heart attacks and strokes and heart failure, acute heart in sudden cardiac deaths. You've heard 4 or 5 deaths in the movie stars, sports people. You've heard of KK. You've heard of Siddharth Shukla, Rajkumar, and all these guys were in their 40s and 50s. And because they were famous, you got to know about it. But believe me, we see that every single day in our clinical practice. More and more young crowd is coming with heart attacks and strokes. So the most important is awareness that, yes, there is a problem. Then we have to screen you. So there is something what we call as a Q risk scoring, or there is a scoring system. And in fact, at Seva at Home, we specifically designed a program for prevention as part of the cardiac rehab, which is a broader spectrum of cardiac rehab, is preventive rehab. And that's a newer concept, which is not usually part of cardiac rehab, but we are trying to catch people at a younger age who are at risk for heart disease. And we calculate the 10-year risk. We call it Q risk 3 score. If the 10-year risk is more than 10%, then they're at very high risk of heart attacks and strokes in the next 10 years. And we actually screen the patients, and it's a very simple algorithm by which we can screen them and tell you that you are at higher or lower risk of future cardiovascular disease. And of course, once we identify that you are at risk, we take aggressive risk factor modification, we give you drugs if necessary, and you have to understand that prevention is the only way forward, especially in a country like ours. And why? Now, if you look at India, only about 6 crore people have suspected coronary artery disease, out of which only 5% would be actually uh, people who would have access to healthcare. Now, today, if you look at angioplasty and angiography in India cost about 10 to 15,000 rupees. If you go to Dubai or if you go to say Europe or America, it would easily cost you about 1 to 1.5 lakhs. A bypass surgery will cost you about 30 to 40 lakhs in US and Europe. It costs only 2.5, 3 lakhs in India. You go to Thailand, you go to Singapore, you get any of these procedures done, it will cost you about 10 times more than what you get in India, at the same level of expertise, probably better in India, and much better quality of medical facilities. So I want to tell you that India is, the healthcare in India is much cheaper as compared to the world over. And we just don't realize how lucky we are that we're able to access this kind of a high-end, care, cardiac care at such a low price. Moving forward, so a healthy heart basically would start with identifying the risk factors in you. Now, I can't change the family history or age or sex. So we know that males less than 50, family history we define as somebody in your family, first degree relative. So father, brother, mother, sister. If your father or brother had heart disease or stroke at less than 55 years of age, or your mother and sister had an heart disease at less than 65 years of age, then you have a positive family history of heart disease or CVD, cardiovascular disease. So age less than 50 in India, I would easily put it at 40, actually, going by the trend. A male, somebody who's a smoker, obese, somebody who doesn't walk, very high psychosocial stress. Now, these are something which are modifiable risk factors, and you should concentrate on that as well. Now, the traditional risk factors like diabetes, hypertension, high cholesterol, high lipoproteinase, another kind of lipid which is coming in a big way, which we call it LP little a or LPA, is also considered a risk factor in Indian subset. And these are having a multiplier effect, which means that if you have diabetes and you're a smoker, then your risk is not 1 + 1, but it is actually exponential. It may be actually 8 to 10 times higher risk for heart disease and heart attacks in future. So if you are a smoker, if you're a hypertensive, if you're a diabetic, if you are sedentary, if you're that typical executive who sits in his room, works on a computer for 10 to 12 hours, eats a lot of junk, is not exercising, a lot of stress, a lot of targets, you are at definitely high risk of future cardiovascular adverse events. So now this is an old study, but this is something which actually shocked us all, because this was a very well-planned study in almost 52 countries, in more than 15,000 individuals. We call it the Interheart study. And it identified 9 risk factors which can lead to heart disease or stroke, or what we call as the cardiovascular disease over the next 10 years. And very predictably, diabetics, hypertensives, smokers, people who have abdominal obesity, who were fat, high ApoB to ApoA1. So this is a kind of a lipid ratio again. Psychosocial factors, very important, something which we traditionally miss out on because they're difficult to quantitate. Lack of regular physical activity, and very, very important, inadequate consumptions of fruits and vegetables. Now, these 9 risk factors were shown to be much higher in the Indian subset or the South Asian subset. It is not that we get heart disease just because we are genetically predisposed. We actually have more of these risk factors. Out of these 9 risk factors, more risk factors are found in Indians. We also tend to have more visceral fat. So I may not look fat, but my visceral or inside fat is much higher as compared to my European counterpart, as was seen in MRI studies. There is also something which is known as fatty liver or a lean lean NAFLD or lean non-alcoholic fatty liver disease, where the patient may not look fat, may be lean, but they may still have fatty liver. So these are the conditions which we see very often in Indians. We also have something very distinct in terms of coronary artery disease. So traditionally, out of the four lipid profile, LDL, triglyceride, HDL, the total cholesterol, the most important one-to-one correlation with heart disease is of LDL. So if your LDL is higher, you tend to have higher risk of coronary artery disease and strokes in the near 10 years or 20 years. But in Indians, we've seen a different type of atherogenic dyslipidemia, and that is high triglyceride and low HDL. So HDL is usually the good one, and LDL and triglyceride are the bad cholesterol. So in Indians, we've seen higher triglyceride, lower HDL, and not so high LDL. So an atherogenic dyslipidemia of this kind leads to coronary artery disease, especially in diabetics and smokers, which are arteries become very thin, diffusely diseased, multiple blocks, and these are very difficult to treat coronary artery disease patients. We are the diabetes capital of the world, and diabetes gives a very high cardiovascular risk. So is the hypertension, and we are going to be, in 2025, we will actually surpass China. We already have. We are also the hypertensive capital of the world. And as I had said, that the higher the cholesterol, especially the LDL, higher is the coronary artery disease risk. In India, 1/3 of the population is obese and becoming worse. You can see obesity even in children nowadays. And what we detect clinically is actually the tip of the iceberg. We detect very few people who have coronary artery disease. And actually, a lot of us are harboring risk factors which can lead to heart disease suddenly without a warning. And this is one of the most important slides of the talk. So if you look at this artery here, this is a normal coronary artery with no plaquing. And this is a 90% block artery on the right side, extreme right. You can see a very small hole of blood flow here. Now, in between, you have these 50 to 70% plaques. You can see a large lipid core, which is this yellow. Upper layer is thin. And these actually, if you look at the risk of complications, which means risk of heart attack and strokes, it is highest in the 50 to 70% bracket, in this bracket. Now, none of my tests, which I do, treadmill test, stress echo, even if I do a CT angio, and I pick up a block which is less than 70%, it will fall into this category. So I'm going to say that you don't need any stenting or bypass because your blockage is less than 70%. But these are the plaques which are soft. They have a thin upper layer. They burst very easily. We call them vulnerable plaques, and they can cause heart attack or stroke without any warning in a previously healthy person. And that is why it is important to understand that it is not important how much is my blockage. For example, this individual can be a farmer with 90% block. So here the lipid core is small, this yellow part. And layer by layer, this fibrous layer has formed over many 30, 40 years. So this plaque is hard. It will not burst. It will give symptoms when the plaquing is beyond 70%, but it may never lead to a heart attack. So a farmer or a kisan working in a village may be having all the 3 coronary arteries blocked 90%, but may never have a heart attack. Whereas a 45 or 50-year-old with no apparent risk factors or problems can land up with a heart attack in your emergency. And that's what we're seeing every single day. Now, how can you detect these patients? So one, I said that we need to do a Q-risk scoring, which we do at Seva at Home in a lot of our patients who we screen as part of executive health checks. We even have kiosks in societies where we screen people as in early morning walks, etc. So this is basically what we're proposing is a doorstep screening. We're coming to you and telling you, okay, you are at risk or not. It's almost like a service we're giving back to you so that we can pick your risk factors early on in life and tell you what to do. Apart from that, there are various very simple modalities, like for example, intima medial thickness. So this is an ultrasound of the neck. We call it carotid intramedial thickness, carotid IMT. And if it is very thick, more than 1 millimeter or so, then we know that it is at higher risk of heart disease in future. So this is a Normal intima, you can see this layer is what we're looking at. This is a thick intima, and this can give us a idea about your future risk. The other is something which I use very frequently. A lot of people use coronary CT angiography. I don't agree with that. CT angiography basically means that I'm giving you an injection or a dye, which is 110 ml, and I'm using a lot of radiation. But I do use it in selected patients where my risk for coronary artery disease in a patient is high. But in most people, if I have to screen, suppose I find somebody who has a family history, suppose I find 2, 3 risk factors and I want to start a cholesterol lowering drug or a statin in them, I may simply do a plain CT scan with no dye, no injections. It's called coronary artery calcium scoring, CT coronary calcium score. So this score gives you, normal score is 0. If the calcium score is high, then we can take preventive action early on in life. And this is usually proposed for people who are above 40 years of age. Yes, in some of the people, if we find that the risk is higher, we can do a CT coronary angiography, which gives me a pretty good idea about your coronaries without actually taking you to cath lab. This is done in a OPD basis, and it's a good modality. And this is what calcium score looks like. You can see this is a calcium deposition in the coronary arteries. This is without any dye injections. Now, when we talk about treatment, what do we do when we actually say that we are going to take you for an angiography or angioplasty? Now, here I want to tell you very important distinction, and there are a lot of myths going on about somebody. So let us first understand what is a heart pain look. What does a heart pain look like or feel like? So normally the heart is a visceral organ. It's a deep organ. Any pinprick, localized pain like here, pinprick kind of a pointed pain, which comes for a few seconds, goes away, can never be heart. Heart pain will come when this plaque is causing at least 70 to 80% obstruction. And if there is a clot which comes and blocks it, that's when you're going to get a pain suddenly. So there are 2 types of pain. One is acute pain and the other is a chronic pain. So acute pain means I'm sitting comfortably, I'm walking around. Suddenly I get this very severe chest pain in the center of the chest, squeezing as if somebody has squeezed my chest, and it spreads like a band throughout my chest, goes into the arms, jaw. I start sweating. That's a classical heart attack, right? That's an unstable angina, heart attack. You have to rush to the hospital where we do a coronary angiography, look at the blockage and open it up. That is called primary angioplasty. A lot of people will say, ये ऐसे ही बोल रहे हैं, मेरे को कुछ नहीं हुआ है, मेरे को गैस है, ये है. But please understand that ECGs don't lie. There is another blood test which is ECG will pick up only 50% of heart attacks. So you have to do a blood test called troponin test, which is a blood test. And it can give you, if it is high, you have to get admitted and get an angiography and angioplasty done. The second type of heart pain is called angina, chronic angina or chronic coronary syndrome, where it is a predictable angina. I walk 500 meters, I get this heaviness in the chest. If I keep walking, it will spread to my jaw, arms, etc. back. If I stop, it will go away. Now that's a predictable or stable angina. And that is also means that my artery is at least 70% or more blocked. But here there is no emergency. You may seek medical help, and most of the anginal symptoms like breathing difficulty, chest pain, fatigue occur when the artery is more than 70% blocked. When you are getting an acute chest pain, please do not hesitate to go for an angiography and angioplasty, which is known as primary angioplasty. That is very, very important. Don't get into this thing that there is a clot buster drug. Yes, in smaller towns, we have, if you don't have the facility of angioplasty, then you can go for a clot buster drug like TPA or tenecteplase, which can, in 70% patients, open up the artery. But angioplasty can open it up in 100% people. And this is what a angioplasty looks like. So this is a plaque. You can see a yellow plaque. This we pass on the wire, and this is a balloon-tipped catheter which we pass. So this is the balloon mounted on a catheter. We inflate the balloon from outside, crushing the plaque and opening the artery. So this is the balloon. This is called balloon angioplasty. We take out the balloon, And we take another balloon which is wrapped with a stent. Stent is nothing but like a metal scaffolding or spring, which is on top of the balloon. We again inflate the balloon, and the stent acts like a scaffolding to keep the artery open. So this is what a stent implantation looks like. And the entire procedure is called angioplasty with ballooning. PTCA or PCI with stenting is what it is known as. Now, in some of the patients, we may have to do a beating heart surgery. So this is how advanced the cardiac surgery. This is a beating heart. This is called the octopus, which actually holds the heart while we are doing the surgery. And this is the vacuum suction, which actually holds the heart still while we are suturing the coronary artery grafts on top of the beating heart, which is underneath. So these are beating heart bypass surgeries, which are open heart surgeries, but are very, very safe with very quick recovery. Now, the last few slides are about prevention. So, of course, weight reduction is very important. Increase physical activity. You have to cut down on your carbohydrates and fats. And the worst kind of food is, so what we follow is what is recommended by the American Heart Association is a food pyramid. The ones which are grains, vegetables, milk, fruits are in higher quantities. You can say this is called a food pyramid. The oils are less. Meats, especially red meats, are on the lesser side. The ones which you should really have in a lot of quantity is, this was the older pyramid where you had the food groups which are recommended, which is grains, etc., vegetables on the lower side. But now there is a vertical pyramid like this and a man walking on the side, which means that diet alone without exercise means nothing. So you have to have half of all the grains consumed should be whole grains. And you should take more and more fruits and vegetables in your diet, which lowers the risk of heart disease. So at least 2 to 3 cups. And low-fat dairy products, milk, and of course, lean cuts, seafood and beans, and avoid frying. So this is the basic tenet of healthy food. And very, very important is at least 30 minutes of physical activity of moderate level in adults, and about 60 minutes for children is recommended. You should be clocking at least 150 minutes per week of exercise, mild to at least moderate degree, which is brisk walking, jogging, maybe some core exercises, yoga, etc., in your daily routine. So the one very simple tips is that you keep a display of fresh fruits in a bowl in a kitchen. Don't have chips, etc., in your cupboards. Anything which you can keep in the fridge or in the cupboards will have saturated fats, because that's the only way it can stay for many months without getting perishable. So serve fresh fruits for desserts. Avoid high calorie or high like Indian sweets tend to be very, very high calorie and a lot of very high content in sugar. So you can buy low or non-fat yogurt, sometimes fresh fruits for dessert, or even frozen banana berries, etc., which can substitute for a carb or sweets. And the untouchables, of course, we all know it, but very few actually not touch it. And I would tell you that these are some things which you should avoid at all costs. Very, very randomly you may pick them up, but most of the times they're very bad for your health. The ones which you should eat are the fruits and veggies as much as possible, at least 2 to 3 portions. Eggs are good. So 1 egg a day, including the yellow, is quite all right. The previous theory of yellow being bad is completely trashed now by the same society which proposed it, which is the American Society. So eggs are healthy. Which fat? Again, there are 150 diets plans and a lot of issues on which fat should you take. But overall, anything which has a good MUFA, which is mono unsaturated, and PUFA, which is polyunsaturated fat, in good quantities, they're all right. So olive oil is not supposed to be something which is like out of the world. It is one of the good oils. Canola, peanut oil, etc., are good oils. The ones which are good in PUFA are fish, vegetables, nuts are very good actually. Avoid hydrogenated oils. avoid margarine or vegetable oils, fried chips, go for baked goods, etc. You can have whole milk, butter, cheese in a smaller quantities, but go for low fat dairy as far as possible. Desi ghee is quite all right if you're taking it in small quantities because it has a good mufa and pufa content. So you may not fry in it, but you can use it sparingly. The best is to rotate your oils. Like the Indian cooking is mostly in desi ghee and mustard oil, kachi ghani, sarson ka tel, which are both good oils, and ghee. So idea is to rotate your oils. Do not make all the vegetables and dishes in one oil. Keep rotating it, and I think you'll be good. So 3 to 4 tablespoons a day is quite all right when you're using oil. Now, alcohol. Now, alcohol is not directly implicated with heart attacks, but we know that higher the alcohol content, higher the risk of cancers. So the maximum permissible drinks are actually less than 45 ml in a man and less than 30 ml in a woman on a daily basis, provided that there is an increased risk of cancers in these individuals. So you should avoid alcohol as far as possible. At least the binge drinking should be avoidable. And as far as possible, minimize the alcohol. I'm not asking you to stop it, but you definitely need to minimize its usage. The fish oil or fish in your, so freshwater fish is quite good for your health. At least 2 servings per week of fish is good. Nuts are healthy. So especially your almonds and cashew nuts are not supposed to be that healthy, but your almonds are good. Pistachio is quite good. So most of the nuts are actually healthy to take. Physical activity, we've already said that at least 30 minutes, 5 days a week. And it should always be an emphasis on meditation and recreation, which is very, very important part of psychosocial health. So take up some sport, listen to music, relax, don't have very long days, sleep very, very well, because lack of sleep is one of the major risk factors for hypertension, uncontrolled diabetes, obesity, and that is something which you should emphasize upon. So healthy eating, being active, smoke-free, reducing alcohol, and trimming excess weight will lead you to healthy heart and prevent heart disease. Thank you.
That was splendid indeed, Dr. Vinayak. A lot of interesting tips there. So there are some questions in the Q&A box which I will read out to you for you to answer. But before that, in a lighter vein, do you mend broken hearts?
Huh?
Do you mend broken hearts?
Yeah, absolutely. So there is actually a very interesting anecdote about broken hearts. There is actually a syndrome which is known as broken heart syndrome. And this is also known as stress cardiomyopathy. Usually it was seen in women in their 40s who've had some trauma or grief and presenting like a heart attack in emergency. But now we're seeing a lot of broken heart syndromes in a lot of patients admitted in ICUs, sepsis, many other diseases. So yeah, it's actually, a scientific term as well.
Yes. All right. So, doctor, why are so many young people? You mentioned that there are young people getting heart attacks. Why is that happening?
That's a very important question, and I think in India it is taking much more, I would say, much more emphasis is required on that. The reason is that we in India are plagued by many ills. We are stressed out. So if you look at the younger crowd, they have a lot of stress to make it big early on. They have stress. They're competing at various levels. The job stress, target levels. The lifestyle is something which has gone for a six. So they have longer travels, a lot of air pollution, not very good food habits. They have traditionally moved from the village, the rural, eating habits which were good to urban habits which are bad. So a lot of them smoke, A lot of them drink, a lot of them have a junk food, long nights, not enough physical activity, lot of stress. So there is basically a accumulation of risk factors in the younger generation. And imagine if this kind of an activity starts at the age of say 16, 17, by the time you're 35, you've already been exposed to 15 years of bad habits or bad cholesterol or bad stress, which was all leading to inflammation. That's why you're getting more and more heart attacks at an early stage.
Yeah, what a
Genetics
pity. I
also
mean,
plays a part.
yes. No, you have mentioned in your presentation a lot of tips to avoid a cardiac event. And I think we can only do our best to sort of live our life in a manner that we don't have an event like that. So there is a question from one of the participants here, that is it possible to reverse coronary artery disease by doing regular exercises? Reverse.
So that's a, I'll answer it at two levels. One, once the plaque is formed, you can, so these plaques are stony hard, okay? You cannot remove these plaques once they're formed. But what happens is that if you start exercising, there is an adaptation of the coronary artery by what is known as Glebov effect. So if this is the artery and there is a plaque inside, the artery starts to expand on the other side, which is healthy. So the lumen doesn't get compromised, and there is a positive remodeling of the coronary artery, and you may have plaques, but you may never have symptoms. This is very typical of the villagers, etc., or people who are working in the fields. They're also smoking hookah and a lot of oily stuff, etc. They may have, but because they're exercising a lot, so the plaques are stable, they are hard. There is a positive remodeling of the arteries, and hence they don't get symptoms or heart attacks as often as their, say, urban counterparts.
So doctor, when you talk about symptoms of heart attack, is there a relationship between the pain in the left arm with the heart attack?
Yeah, so that's a good question, because I keep getting a lot of calls about that. I got a pain in my shoulder, it's going down my arm, can it be heart? So I want to tell you 2-3 things about the character of the pain. Now, as I said, that any pinprick, localized pain, any pain which increases on movement like this, or radiating. Suppose I lift my arm, I get a pain in my arm going to the, to the arm as well as back. All these kinds of pains can never be heart. Heart pain is usually in the center of the chest, what we call, so I'll show you with my hands. So this is the center of the chest. We call it retrosternum. Usually the heart pain starts here, not on right or left, though it can be on any part of the chest. Usually it is not localized like this. This is usually muscular. If it's, a lot of people say I'm getting pain here, that kind of pain is never heart. This is a diffuse pain which you cannot localize with a finger or with few fingers. It increases when you walk. It is usually accompanied by breathlessness. If you slow down or sit down, it will go away. So that is a classical angina, but any pain which is lasting for many days, radiating from your shoulder, but is not affected by movement or exercise or exertion, their chances of being a heart pain is very, very unlikely.
So when you're talking about symptoms, does a heart attack get disguised as just some gas in the stomach, for example?
Yes, it does. It can. So if suppose I find, we are caught in a conundrum nowadays. Classically, about 15-20 years back, we used to say if you're a diabetic, hypertensive, smoker, and if you get a stomach upset, like some epigastric pain is here in the center. This is the epigastrium. Pain here, and you have one or two loose motions, you have burping, then we'll say it's a food poisoning hoga, stomach upset hai, so don't worry. Just take some Digene, take some Pentosed, etc., and everything will be fine. That is not true. Now, in diabetics, hypertensives, etc., we find that this can sometimes be mimicked by a heart attack. So when the right coronary artery of the heart is affected, which is touching the diaphragm, It may mimic symptoms of what you call as gas or upset stomach. Now, what I would suggest is that if you have risk factors, like what out of the 9 risk factors that we said, then, and if you're in the bracket of say 35, 40 years, and you have risk factors like diabetes, smoking, hypertension, you get this kind of a epigastric discomfort. It's not a bad idea to go for an ECG if the pain persists, especially if this discomfort increases on walking or on exertion, or is brought on with some kind of a breathlessness. Then you should definitely not ignore it.
Doctor, does someone with acute hyperthyroidism develop coronary artery disease?
Acute what?
Hyperthyroidism.
Hyperthyroid. So thyroid can be hyper, which means it is secreting a lot of thyroid hormone, which leads to palpitations, increased heart rate, sweating, weight loss, basically signs of high catabolism. They usually don't present with heart attacks. I mean, it's not a risk factor for heart attacks, but it may mimic a lot of palpitations, uneasiness. Sometimes they even have dyspnea, breathlessness, etc. Hypothyroidism, on the other hand, leads to weight gain. Again, palpitations can occur. They can sometimes lead to fluid accumulation around the heart, slowing down of the heart rate, swelling in the legs, but not directly linked with a heart attack. They may lead to hypertension, but not heart attack in direct correlation.
Right. What is your take, doctor, on COVID vaccines? Would they trigger heart attacks?
No, that's a very controversial field. Now, I'll try to answer it in 2 ways. If you look at pre-COVID era, especially in US, whenever there was an influenza epidemic, so influenza season comes somewhere in September, October, a little wintry season, you would see the risk of heart attacks go up. This is pre-COVID era that we're talking about, which means that there is a direct link of viral infections, including influenza, etc., and heart disease and strokes. Now, COVID is no different. COVID is just like another influenza-like illness, which came and it increased the risk of heart attacks and strokes. Now, this is the theory. Surprisingly, during COVID times, we saw a decrease in the heart attack rates in a lot of states. Some people said that people, because of being afraid to go to the hospitals because of COVID, never reached the hospital. Some of them died at home and never reached, so the amount of the count of heart attacks and strokes were less. On the other hand, we can also admit that since the people were staying home, they had less risk factors, less exposition, less exposed to outside food, less air pollution, less stress of working. So the risk of heart attacks and strokes went down because their overall quality of life improved. So they were living more healthy at home and not exposed to external input. So the overall risk factors of heart attack, stroke went down. The other way to look at it is the vaccine. Now, when you give vaccine at mass scale in crores, anything that happens can be linked to the vaccine. But like any other vaccine, COVID vaccines has been associated with at least slightly enhanced risk of heart attacks, myocarditis, pericarditis, which means that the layers of the heart get inflamed. And these are very few cases, transient. Most of them recover automatically within a few days. Why I say this is that I would still recommend that each of us should have, if not yet, go for vaccinations and not be bothered about these very minuscule number of cases which may be related to vaccine.
Doctor, is the dye that is used for the angiogram, is that harmful for the kidneys?
That's a good question. Now, nowadays, what we do is we use dyes which are very safe. They are isosmolar, so the risk to the kidney is minimal. And the amount of dye that we use in angiography today is hardly 30 ml. Compare it with a CT coronary angiogram or a CT of the head, contrast CT of the chest, where we'll use much more dye. So the risk of kidney getting damaged, even in a patient of kidney disease, is very, very low. In a normal individual, it is almost negligible. We've hardly come across any problems to the kidneys in a normal individual. But even in kidney patients, patients who have kidney disease, we do angiography routinely with some precautions, and they are usually safe.
So here's a question from one of the participants, which says, I was done with angioplasty with 2 stents. Is there any validity period for stents? As a heart patient, how can I self-diagnose? There was no blocks in my heart and my heart condition was good. And I'm doing regular checkup. And how frequent do I need to get my cholesterol tested and echo done? How does one increase the LVEF percentage? I have 45%. And my doctor suggested me some medicines like Dapify and Dapagliflozin and things like that. So this is, of course,
I will try and not answer it as an individual issue, but I've understood your question, so I'll answer it for the benefit of all the viewers. See, when you say that my heart was good, I'm not sure what you meant, because if you mean that I was running and I was doing everything, but I was still having risk factors which were unattended to, or I did not know about them, then you were not really healthy. A lot of people who think that they're running 5 kilometers a day or doing gymming, they think they're healthy, which I differ. Cholesterol or exercise is just one of the 2 of the 9 risk factors that we're talking about. So you have to look at an overall holistic view of the individual and not just 1 or 2 risk factors or 1 or 2 profiles of the patient. That's number 1. Number 2, once you've had a stent, 45% EF is not bad at all. You can live an absolutely normal life. You can run. In fact, it's a myth that once you're a heart patient, you cannot do exercise, gymming, weightlifting, or even HIIT, high intensity interval training. You can do everything. But of course, with some limitations and absolutely under supervision of not just your trainer, but your cardiologist or your physician. You have to go slow. You have to be, you don't have to prove a point. I've seen a lot of individuals trying to push their bodies because they want to prove a point that I'm strong. That's rubbish, because all that you end up doing is injuring your muscles, having a lot of tear in your, in your muscles, and your coronary artery dissections are common. You're causing a lot of endothelial damage. So please go slow. Your body is built for something, which is routine. And if you need to push it, then you have to go very slow under supervision and gradually reach a level where you can do that kind of exercise. Now, there are some very basic issues. So you need to walk 4 to 5 kilometers a day. If you find any acute change in your symptoms, like sudden onset breathlessness at a lesser distance that you were traveling, any chest discomfort which was not there earlier on exertion, any undue breathlessness, fatigue, you have to report to your doctor. Stents have the life of a stent should be not in terms of years. They can last for 30 years, 40 years also, or they may not last. They can get blocked in 6 months. We talk in percentage of, in percent terms. So if I put 100 stents, there is a chance that 5% of these individuals or 5% stents will get blocked over a few months to few years, depending on your patient profile. Suppose somebody is diabetic, hypertensive, smoker, above 60 years of age, not taking care of themselves, not walking, not taking medication properly, they are at higher risk of reblockages. There are guys who've had stent in 1970s, 80s, and yet all the stents are working. So it's not the duration of the stent in terms of years, but we talk in percentage of risk of restenosis that is more valid to a stent or even to a bypass. In fact, a lot of times the surgeons will tell you that once I put grafts in you, you will be fine for life. That's not true. Even your grafts, the venous grafts last for about 10 to 15 years, and the arterial grafts last for about 15 years to 20 years, depending on patient profile again. So you have to choose wisely in whom to put stents and whom to put grafts. Sometimes you can put both of them. I mean, you can choose either of them in a patient, depending on my personal choice as a doctor and my discussion with you as a patient.
Your answer, doctor, brings me to the question on cardiac rehab. Is there a need for cardiac rehab? What exactly is cardiac rehab?
So it's a very, very important question, and something which unfortunately has been completely missing from India. Cardiac rehabilitation is not a new concept. Cardiac rehab basically means a patient who was diagnosed with heart disease like heart attack, admitted in a hospital with heart failure, heart attack, or had a bypass surgery or a stenting done, is now going home. So how do I make this individual go back to his previous level of normalcy as he was? How do I hold his hand and take him through step by step from phase 1, phase 2, phase 3 to a state that he can go back without any fear to his previous life? For example, once you're in the hospital in phase 1, we give you education about what happened to you, why did you get a heart attack, what did we do to you in terms of stenting, what are the normal expectations, how soon can you start walking, going up the stairs, how soon can you be with your wife or with your partner, in terms of sexual health, how soon can you go back to work, how soon can you drive, what can you eat, can you have say I feel like having a dosa today or a chola bhatura after a month, can I not? You have 100 questions. Now who answers those questions for people who leave the hospital? And this is, we are talking only about cardiac health. So we take you through phase 1, we take you through phase 2, which is at home. So we tell you how to gradually go from 1 week to the second week to the third week. And what we have started is a unique program where it differs from other programs because we have a doctor, a nurse, a physiotherapist visiting your home and teaching you and looking at your profile, evaluating you in totality, and then telling you that these are the problems with you. And we're not looking just at the heart. We're looking at your diabetes, your hypertension, your other problems like rheumatoid arthritis, osteoarthritis, depression, osteopenia, osteoporosis, everything is looked into. And then we gradually, over next 4 weeks, we take you through literally holding your hand to to get back to your normal life. Most of the patients will take about 3 months to get back to, say, a brisk walk of 5-6 kilometers. They can even go to the gym. They can start traveling from 6 weeks onwards. They can fly. They can actually reach the best part of their health as they were, in fact, better. However, there are certain subset of patients who are sick, whose ejection fractions are really low, who are in heart failure, who are delicate, who are still at high risk of sudden cardiac death. And these people require a particularly intensive cardiac rehab at home, where we take them through each and every, so the fluid balance, the weight charting, input-output charting, how much salt to take, which diuretic to add. So you can imagine that cardiac rehabilitation is something which we all need. It also involves a preventive aspect, which we said that a lot of people who, suppose there is a patient in a home, there are 4 other individuals in the house, where we can just simply give them a questionnaire that, okay, let me find if you are at high risk of heart disease in the 10 years time. We call it Q risk scoring. So we look at your screening or as a family as a whole. So cardiac rehab is a concept which is very, very important. It's imagine, suppose one of your family members get admitted with a heart attack and comes back home. Do you know what to do next? You will have 100 questions to ask. You will have 100 questions. You will need answers to which you don't have, because nobody has the time, energy, or the inclination to answer those for you. And that's where we come in and we hold your hand, we take you through the entire process at home. And that's what Seva at Home does actually.
Yeah, that is wonderful, Doctor. Actually, when a patient leaves the hospital after a surgery, it could be a bypass or any other cardiac event, the doctor bids them goodbye, the nursing staff bids them goodbye. You're all right now and you can go back, you've recovered. When the patient goes back home, he's in a state of suspense because he knows that there could be a second event or another event anytime. And that is not good. So that is when he needs a lot of care. And there are so many of these elderly people who do not have anybody to look after them. And on a visit to the hospital, then for a post surgery checkup, or even now, a health checkup or a echo or a ECG could be quite taxing, because one has to take a cab, go to the hospital, wait for the doctor, wait for the lab technician, get the tests done, and come back. So something like a cardiac rehab program where you have to get care in the confines of your home could be a very, very good option. So thank you, actually, doctor, for actually conceptualizing this entire program, cardiac rehab, which we are now at Siva at Home running a pilot in NCR, and we will soon spread this to the entire country. There are a lot of questions in the Q&A box. Unfortunately, we are running out of time, and I must tell the audience that the doctor was indisposed today with a back spasm, but he just wanted to be with all of us here and give his wonderful tips on how to manage oneself, one's life, and have a healthy heart. So thank you so much, Dr. Vinayak Agrawal. It's been such a pleasure talking to you, and I hope you recover from that spasm quickly
Thank you.
and back at work. Thank you so much, audience, for being with us, and see you again in yet another webinar very soon. Good night and have a good day in case you are in another part of the world. Thank you.
Bye.